Assalamualaikum warahmatullahi wabarakatuh. I'm Kenzuraida Maharastri. On behalf of all co-authors, I will present a case report entitled A Rare Case of ST Elevation Myocardial Infarction, Severe Cardiogenic Shock, and Myocarditis Secondary to Leptospirosis. The introduction. Leptospirosis is a zoonosis disease caused by Leptospira. Ratus norvegicus is the primary source of human infections, while several wild and domestic animals can become reservoir hosts. The penetration route includes non-intact skin and the conjunctival or oral mucous membranes. Its incubation period usually ranges from 7 to 12 days. The hematogenous dissemination causes a mild febrile illness to several multiple organ failure, known as Wells disease. However, the extent of cardiac disease following leptospirosis is uncertain and underreported. Thus, we report a rare case of non-severe leptospirosis with cardiac involvement, including ST elevation myocardial infarction, severe cardiogenic shock, and myocarditis at UNS Hospital Surakarta, Indonesia. The case report, a 35-year-old male patient was admitted to the emergency department on June 21, 2022 with fever for 3 days, myalgia in his calves, nausea, vomiting, and diarrhea. He works as a handyman and lives close to the rice fields. There was no recent contact with wild or domesticated animals. No history of hypertension, diabetes, and allergies were found. He has quit smoking for more than 10 years. Further evaluation revealed low addiction for the heaviness of smoking index. On physical examination, he was febrile with epigastric pain. There were no icterus and signs of bleeding. Stool examination showed epithelial cells and leukocytes. The patient was initially diagnosed with a common cold, acute gastroenteritis, and acute kidney injury without any specific laboratory finding. After 24 hours, the patient complained of retrosternal chest pain. Electrocardiogram showed ST elevation in V1 until V6 leads. Elevated high-sensitivity cardiac troponin was also detected. Hence, the patient was diagnosed with anterolateral STEMI. This STEMI is relatively uncommon in young adult patients with low-grade HSI and without a history of hypertension and diabetes. Within the onset of anterolateral STEMI, the patient experienced a severe cardiogenic shock. The blood pressure was 55 per 40 millimeter mercury, heart rate 93 times per minute, respiratory rate 24 times per minute, oxygen saturation 91% on nasal cannula 5 lpm. Acral coldness and prolonged capillary refill time were found. The patient was transferred into the high care unit. We suspect leptospirosis and dengue hemorrhagic fever. This is the laboratory findings. On June 21, the patient showed lymphopenia, neutrophilia, and decreased renal function. Diarrhea due to bacteria and parasite infection were excluded. On June 22, the elevated high-sensitivity cardiac troponin support the diagnosis of myocardial infarction. On June 23, the patient showed thrombocytopenia and diagnosed with dengue fever. From lipid profile examination, low HDL level is the only abnormality as the risk factor of acute coronary syndrome. Further evaluation showed positive for anti-leptospira IgM and negative for both anti-dengue IgM and IgG. Here's the echocardiography. It showed a mild reduction of left ventricular systolic function, grade 3 LV diastolic dysfunction, a positive finding of regional wall motion abnormalities, mild mitral and tricuspid regurgitation, enhanced echogenicity of the lateral LV endocardium. So we interpret as a myocarditis. No evidence of Wells disease found due to the absence of refractory shock, pulmonary hemorrhage, and jaundice. The patient was discharged from HCU to the hospital ward on the 6th day. Home remedies include cardiovascular medication, antibiotics, potassium-sparing diuretics, and omeprazole. So, the conclusion of this case report, the cardiac involvement of STEMI, cardiogenic shock, and myocarditis in a leptospiral suspected patient can cause medical overdiagnosis, although those are secondary to leptospirosis. This atypical organ dysfunction is difficult to describe because of the lack of clear criteria to define cardiac involvement. The possible co-infection of enteric and dengue fever and leptospirosis should also be evaluated in the physical laboratory examination and treatment. This is the end of the presentation. Thank you for your attention.